Today we're going to talk about the guidelines for Chapter 1. I've gone into a lot more detail with Chapter 1 than I will in subsequent chapters. I want you to understand how important the guidelines are and figure out the best way for you to apply them when you are doing your homework. I've made some changes to the annotation, which I'll be reviewing in this PowerPoint. I've also given you some examples of the various guidelines, and from there we'll see what kind of questions come up and how you do on your homework. When you complete your homework for this class, you will have to tell me not only the answer, but the pathway that you used in the index, as well as any instructional notes, and the guideline that you applied in order to know how to code or how to sequence the codes. So let's get started. The first guideline is to code only confirmed cases of HIV. And what that means is whenever the physician uses the terms possible or probable or suspected or questionable or still to be ruled out, those are all things that normally in an inpatient setting you would code as if they existed. But there are certain things you do not code if the physician uses the term possible or probable. What I've given you here in this slide is a possible scenario where the physician might say, patient admitted with anemia with possible HIV infection. You would only code the anemia. I have the anemia here for the index pathway, and the rationale for the code you selected is the HIV is not coded because the physician stated it is possible, only confirmed cases are coded. And there's your coding guideline here. And then I have just a note here that this is an exception. The fact that you are coding something that uses the term possible is an exception to Section 2, Selection of Principal Diagnosis, number H, Uncertain Diagnoses. And then I have it reproduced here with a copy-paste of what that says. So just remember, for an inpatient hospitalization, when you're using the terms possible, probable, suspected, in most cases, you would code that condition as though it existed. There are certain exceptions. HIV is an exception. Later on in this podcast, we'll hear about Zika. The Zika virus infection is an exception. If the physician says, I suspect Zika virus infection, you do not code it. You must code only confirmed. But we're getting ahead of ourselves. We'll go back and look at that a little bit later. There's some other diagnoses that this is the case as well, and we'll be touching base on those as we move through the guidelines for other chapters. Another guideline says patient admitted for HIV-related condition, and this particular one is pneumocystosis, which is due to the Pneumocystis carinii organism. And here I've got the pathways and the rationale. The patient's being admitted for an HIV-related condition, so your principal is going to always be B20, followed by whatever those are for the reported HIV-related conditions. If you are coding an unrelated condition, like if a patient has anemia, but the physician's saying the anemia is not due to the HIV, then you're going to make the anemia be the principal diagnosis. And underlined here with the guideline are the sequencing instructions for how the coder would sequence these diagnoses. If a patient is newly diagnosed with HIV, the point that's being made with this guideline is that whether the person was diagnosed last week, last month, 2 years ago, 10 years ago, that is not determining what the sequencing directions are. The sequencing directions are dictated by whether or not the infection is HIV related. If it's HIV related, the B20 is going to be your principal diagnosis. If the infection or the condition is not HIV related, then that is going to be the principal instead of the HIV. An asymptomatic person, like this person is admitted with appendicitis, is HIV positive but no symptoms, you're going to use the Z21 code for the asymptomatic HIV. If the physician had used the term the patient has AIDS, as you can see from the guideline, you would have to use B20. Or if the patient has had any history ever of having had an HIV-related condition, then you're going to always use B20. You're never going to use Z21. if the patient has asymptomatic HIV infection and is on medications for the HIV, it doesn't change anything. And the guidelines tell us that if the patient is using medication for HIV, there's still going to be a Z21 if they're asymptomatic. A previously diagnosed HIV-related illness. Here, this is making the point that the patient has appendicitis now, which is not HIV-related. However, last year he had a pneumocystis carinii pneumonia, which is an HIV-related condition. Therefore, he would carry the B20 diagnosis and not the Z21. Okay, this guideline has to do with HIV infection in pregnancy, childbirth, and the puerperium. The puerperium is a period of time after the child has been delivered. And then here is your guideline for the 098 code. And I've given you a case here where the patient's 27-year-old admitted with oral thrush associated with her HIV diagnosis. She's 13 weeks pregnant. Previously, she was asymptomatic. So up until now, she had a Z21 diagnosis. But now that she has this thrush that's been associated with HIV, she's going to carry that B20 diagnosis from now on. Then the thrush is the B37.0. You always assign codes for the weeks of gestation when your 098 code is the principal diagnosis, because that's the reason why she's being admitted to pregnancy complicated by HIV disease. Then here in italics, it says codes from Chapter 15 always take sequencing priority. That's something that we have to just remember as we're moving through the record, and I'll be reminding you of that in your homework in different places, that the Chapter 15, your pregnancy codes, always take sequencing priority. It is very, very rare that a pregnant woman would be admitted to the hospital that wouldn't have a diagnosis that starts with pregnancy complicated by, whatever the reason is for her admission. Obviously, if she's being admitted in labor, that's different, but anything prior to labor is going to be a complication of the pregnancy. Now we've finished the HIV guidelines, and now we're going to look at a few others. This one has to do with infectious agents as the cause of disease classified to other chapters. And what that is, if there is an infection and in the description of the code it does not mention the organism, then you're going to need to use a code from the range of B95 to B97 to be sure that you can capture the organism responsible. So here's the case in point: patient admitted for treatment of a UTI caused by E. coli. We know that the E. coli is causing the infection, but our code N39.0 does not include the cause of the infection. So we would have to add that code. And there's also an instructional note under the N49.0 code that says use additional code B95 through B97 to identify the infectious agent. As the cause of disease, look under infection, E. coli as cause of disease, classified elsewhere B96.20, and that would be the organism code. So now we know what the infection is and what's caused it. Then the rationale I've given you is the guideline that's used, telling us, this guideline tells us if the organism is not in the code description, then you're going to have to add a code that identifies the organism. Because we know what it is. We just have to be sure that we have let the doctor know or the reader know what the offending organism is. Okay, here I have taken that same diagnostic statement and just added the infection is resistant to vancomycin. So now we've got the N39.0 as our infection. We've added the B96.20 identifying the E. coli as the organism. And now we want to be sure we add this resistance to vancomycin because that might be important. I have here the path and the index and how you find the code. Then the rationale, being we would use the guideline that was listed on the previous slide about the identifying the cause of the disease with a code from Chapter 1. And then the resistance to antibiotic, the Z16 code, we would use that as well. You notice in the guideline it only says the category. It says category Z16. That tells us that there's some codes in there, that some characters that would follow that Z16 code. So when we go to the actual category, Z16, and read down, we can identify the drug that the person is resistant to, and in this case it is vancomycin. You can never go by your guidelines or your index and say that's your answer. You have to always go back to the tabular, which is all the codes in the back of the book, to verify that that's your answer. The terms sepsis and severe sepsis are different. This particular guideline has to do with the coding of severe sepsis. And you see in the diagnostic statement where the physician states the patient has developed severe sepsis and acute kidney failure, and you're going to code the severe sepsis and the failure of the kidney. And I have the instructional notes that are found in the tabular under each one of those codes. And then here's the guideline that helps us in this case to know how we would code this. The sequencing of codes is important. It's not good enough to just get the right codes. And the reason for that, as you learn more about coding, is that the principal diagnosis, the first diagnosis that you choose and the one that is chiefly responsible for the patient's admission to the hospital, that diagnosis, along with the secondary diagnosis and any procedures, the patient's age, that kind of thing, drives what's called the DRG. The DRG is part of the payment system for how the hospital is reimbursed. So you always want to accurately code the principal, because that's your principal driver for which DRG is going to be selected. We'll be talking a lot more about DRGs later in the course, but the point I want to make is that it's not good enough to just have the right codes. You must have them in the correct order. And this guideline, and many guidelines, tell us how to order the codes. This first one says a code for the underlying systemic infection is first, that's your N39.0, followed by a code from subcategory R65.2, here you go, and then additional code for the associated acute organ dysfunction, and that's your acute kidney failure here. Now the B96 code would go after N39 because they go together. The B96 is saying, wait, E. coli is the reason for this UTI. So this would be the correct sequence of this diagnostic statement. Sepsis due to a post-procedural infection. This is another example where the guideline tells us exactly how to sequence the codes. The patient developed sepsis with MRSA infection of the superficial incisional surgical site following a total hip replacement. You see your main term infection, post-op wound, and a very specific description of surgical site, superficial incisional, T81.41-. When we go to that code in the tabular, there is an instructional note that says to use an additional code to identify the infection. You also see in our guideline, it tells us that whenever we have that sepsis due to a post-procedural infection, we're also going to be coding the sepsis following a procedure, which is T81.44. That is your main term sepsis, post-procedural subterm. And the last one you're going to code is using sepsis as your main term due to Staphylococcus aureus MRSA A41.02, or you could also use MRSA as your main term and find MRSA sepsis A41.02. You need as a statement, and you would code A92.5 if you had the case where the patient has all these symptoms and the doctor's saying, I think it's probable this is a Zika infection. You cannot code infection with the Zika virus if the doctor's using that term, because that term means it's not confirmed. So in that case, you're only going to code the symptoms.